So welcome everyone to our ACTA STInG webinar today. My name's Andrew Forbes from Monash University, and I co-chair ACTA STInG with Kate Lee from Murdoch Children's Research Institute. And we're delighted today to have Professor Margarita Moreno-Betancourt present to us on a really important topic and an area that's gaining prominence in observational studies, and that's the target trial framework for causal inference. And we're going to hear today about a primer of that. I'd like to start off with an acknowledgement of country. I'd like to begin by acknowledging traditional custodians on the lands which we're all meeting today. For me, it's the Bunurong people of the Kulin Nations, and pay respects to their elders past, present and emerging, and also of those of the lands on which you're currently on. And we extend that respect to Aboriginal and Torres Strait Islanders who may be here with us here today. Okay, we've got our usual housekeeping here, so please make sure your microphone's on mute. We'll send you a nasty message if it's not and there's any background noise. Margarita's happy to take questions during the talk, so feel free to use either the Q&A button or the chat button and type your question in there, and I'll be monitoring that closely. And if the question's relevant for exactly what Margarita is talking about at that time, I'll interrupt Margarita with permission, and then we'll have that question addressed during the talk. And of course, we'll have questions at the end. So any questions not addressed during, we'll try and capture them all at the end. And this webinar is recorded as usual, and it's going to be available on the ACTA STInG website and also our YouTube channel, which I don't know how many followers we have, but if you haven't subscribed already to the ACTA STInG YouTube channel, please do. And at the end of the talk, we've got a little survey for you to complete, and so you'll get that by email. Okay, so I've already mentioned about the target trial framework. So in observational studies, there's a fairly new paradigm that's come up with the sort of explosion of causal inference thinking about trying to emulate a randomized trial when you have non-randomized data. So this is particularly relevant to our registry colleagues, because there would be a host of untapped questions, causal questions you might want to ask from registries, and the target trial framework is going to be extremely useful for doing that. And it's also useful for pure observational studies and also for randomized studies when things don't get perfect, like with, for example, when you have non-adherence to treatment. Okay, and our speaker, Margarita, she wears many hats. So first of all, she's co-director of CEBU, the Clinical Epidemiology and Biostatistics Unit at the Murdoch Children's Research Institute. She has established in a remarkably short time an international reputation for methods and applications of causal inference in observational studies. She's received multiple fellowships over her time since she came to Australia, which I think was what, 2012, 2013 or so.
2013.
And 2013, yes. 14, okay. So she's currently the chair of VicBiostat, a Victorian Centre for Biostatistics, and she's also on steering group for, now I learned this off by heart before, Life Course program at MCRI, Life Course platform, yes, and is involved in sort of steering the direction of a Master of Biostatistics. And she received the Moran Medal by the Australian Academy of Science in 2025. So, and she's, sorry, now I saw the slide. She's editor of the journal Epidemiology too. So Margarita is extremely well credentialed, and I really look forward to your talk on target trial emulation and the framework. So over to you, Margarita. Thanks.
Thanks, Andrew. That was especially embarrassing introduction, but great to be here, and thanks so much for inviting me. It's really cool to talk to kind of different audience that I never get to talk to, but really relevant because I guess we're all trying to start doing causal inference, so very relevant to all that we're doing here as well. So hopefully, I think this talk might be of interest to everyone working across trials and registers. So I'll start with taking a little bit of a step back and give a little bit of an overview of what is causal inference and sort of brief history of like developments in the recent decades that have led us to where we are now, and especially emphasize 3 key steps in causal inference that we need to think about however we're doing causal inference. And then that will provide a good foundation to start talking about the target trial framework and how it works, which I will illustrate through an example from our work here at MCRI. And then I'm going to just touch base on what are the sort of advantages of this approach and also the limitations or challenges that we still face with it. So it's not magic bullet for everything. All right. So, and also just, I guess, disclaimer, I obviously work in the area in methodological research, so I'm bringing you my perspective on things, and you might get a slightly different talk from anyone, or a very different talk from anyone who works in researches target trial emulation and causal inference more generally from a methodological standpoint. So yes, you get to hear my review of things, which is not the only view. So what is causal inference? So that's one thing, for example, that not everyone agrees with, but by causal inference, what I mean is what sort of Miguel Hernan, Robbins, who I will cite quite a lot throughout the talk, mean, which is when we want to answer questions about intervention. So what if someone got an intervention versus what if someone got another intervention? For instance, what if patients take a medication versus this other one? What if children go to childcare and what if they don't in terms of their developmental outcomes? What if I were able to reduce inflammation? Would that reduce cardiometabolic risk? What if I could prevent socioeconomic disadvantage and so on? There's so many causal questions that we ask in health and medical research. And this focus on this interventionist sort of point of view is really underpinned by this mantra of no causation without manipulation. There's like a philosophical debate about what causality means, and essentially in health and medical research, because we're interested in what actions we can do to improve population and patient health, then it makes sense to focus on this sort of interventionist approach. And indeed, examining the causal effects of interventions, whether hypothetical or actual existing interventions, is a central goal of many health research studies. Even if the causal goal is very often unadmitted. So there's a plethora of papers out there on observational research that look at associations without sort of really stating that what they're rather interested in is in the causal effect of whatever they're studying. So I point you there to Miguel's paper called The C Word, a scientific euphemisms or something like that is the title, but it's about how this, for a while, this talking about causal inference was a bit of a taboo in observational research in particular. So just to quickly, briefly talk about how we can assess the causal effects of interventions. So one thing we might be interested in is in the individual causal effects. So we would like to, for each individual, look at their outcome under one intervention, for example, no aspirin versus if they take aspirin, and compare that. That would be the individual causal effect of taking aspirin versus not. But this is usually unachievable in health and medical research because we cannot observe individuals in these two counterfactual worlds where we observe them under two different interventions. So what we focus on mostly is on population causal effect, which is really about comparing average outcomes between groups under one intervention versus the other. So in this slide we have, and I hope you can see my pointer. Can you see my mouse moving? Someone can tell me, just so I know. Um,
Can you move it around again, Margarita?
can you see it there?
We can see it just small, yeah.
Okay.
Oh, yes, it's quite
Wonder.
small. Yes.
Yes, I wonder if I can make it bigger. Oh, yeah, I can use the PowerPoint. This is better, I assume.
Yeah, that's great.
This,
That's
okay, cool. So we're looking at the average, so population causal effect. So comparing average outcomes between groups under an intervention, no aspirin, and here under aspirin. And these population causal effects can be estimated in an ideal randomized controlled trial, which you all know all about. Well, randomized controlled trials, at least. And as you all know, still that real randomized trials are not always feasible, ethical, or timely, or ideal. There's always issues that come up. And for example, in terms of when they're not feasible or ethical, maybe looking at the effects of smoking, for example, mental illness, adversity, inflammation, it's not always feasible to look at those effects. So obviously comes the question, can we estimate causal effects using observational data in observational studies where we have not done some randomization? And so by observational data, what we mean is any sort of data, really, like it can be research studies, like data that has been collected as part of a longitudinal cohort study, like a research study, for example, but it can also be data has been collected during routine medical care, like medical registries, as is of interest here, but also electronic medical records, linked administrative data, any other sort of routinely collected data. We can also ask whether we can estimate causal effects from that. And indeed, from data of randomized controlled trials when interest is beyond the intention to treat effect. So when there's non-adherence or other sorts of intercurrent events. So that is a question, I guess, that has been asked for many decades, but obviously in statistics, it was known that association does not imply causation. And actually, in the early days of statistics in the beginning of last century, statistics sort of evolved away from the study of causality. Carl Pearson, one of the fathers of statistics, believed that causality should be eliminated from science, that it was sort of impossible to look at that. And then Fisher, of course, sort of revived that through proposing the randomized control trial, but didn't examine if causality could be examined beyond that. So apart from the randomized control trials, statistics sort of developed away from that and focused more on developing tools to model data in service of like trying to find the model that best fit the data and then seeing how that model could be used to answer a question, which kind of is the other way around as we would want it. We would want to start with the scientific purpose and then tailor the method to that. So that has led to a lot of issues with how statistical methods are used, in particular multivariable regression, for example. There's a paper there with my colleague John Carlin talking about the uses and abuses of regression. But in health research, if we start to try to think about the purposes before the scientific purposes, there's like basically three types of research purpose that we are usually interested in. So descriptive purpose, which is looking to how big is the health problem that we're interested in across time, across place and context. There's the predictive purpose, where we're looking at who is most likely to experience or be affected by a problem. And then the causal purpose, which is about what actions can we do to solve the problem. And there's this nice paper by Miguel Hernan on those three tasks, so really arguing how those are the only types of tasks that we are interested in health research. And then, obviously, despite statistics going in this direction, sort of going away from causality, health research studies continue to ask causal questions, because that's what health research really cares about. So thankfully, around the 70s, started a sort of revolution in statistics starting with Donald Rubin, who provided a mathematical formulation for that claim about the association does not imply causation, using so-called potential outcomes notation. And that made it possible to start distinguishing settings where maybe association does imply causation and under what assumptions. And then from then on, there have been many developments by Jamie Robbins, Judah Pearl, Miguel Hernan, and many others, amongst which the target trial framework, which have sort of renewed the possibility of methodological developments for causal inference in statistics. And so that has sort of allowed us to go back and stop you thinking of causal inference as a taboo, but actually sort of take the bull by the horn, say, I have a causal question, and how can I answer it with both observational data, but also real world randomized trials. So there's many, like of all the people that I've mentioned, there are many others. There's been many sort of frameworks for causal inference proposed, but there's something that is common to all of them, and is the distinction between these sort of 3 steps that I have here in the slide. The first step is to define the causal estimate. That's sort of like the hypothetical quantity that we want to estimate. The second step is often known as identifiability, which is sort of expressing that estimate in terms of the data that I do observe in my study. And to do that, I need assumptions, and I'll talk about those in a bit. And then finally, specifying the method of estimation with data. So it's only the third step where we actually go and analyze data. And each of the steps really has some assumptions that are involved. In defining our estimate, we have estimate assumptions, which really are around like the value judgment of what sort of questions I'm asking. In expressing the estimate in terms of my data, I need causal assumptions, and we'll talk about some of those later. And then in the last step, we have parametric modeling assumptions, the sort of classical assumptions that statisticians used to worry about, like linearity and those sort of things. And importantly, to examine the assumptions in the first 2 steps, the estimate assumptions and the causal assumptions, we need subject matter knowledge, not data. They cannot be verified from the data. All right, so these 3 steps sort of provide the basis of any approach to do causal inference. And so it's important to think about when we're doing causal inference, for example, in actual trials, what we do in that maps to those 3 steps. So that's sort of what I have in this sort of diagram. Whether we're conducting actual randomized trials or whether we're emulating target trials using observational data, there are parts of those endeavors that map to defining causal estimates, and they can be done in different ways. So I'm obviously going to talk more about the observational studies emulating target trials, but I'll come back to the actual trials at the very end. So that sort of leads into talking more about this target trial framework and how it works. So just what it is, it's an approach that is consistent with those three steps. And what it helps us is to guide the planning and conduct and interpretation of causal analysis. So the first step, and I'll illustrate all the steps with an example in the following slides. But the first step is to specify the target trial as an ideal trial that we would have conducted to, if possible, to answer the causal question. And that corresponds, if I go back to my other slides, to where I define the causal estimate. The second step is to design the emulation of the target trial, that basic with the observational data. So that corresponds to when I'm trying to express the estimate in terms of the observational study, the observational data, and that requires some assumptions. And then the third step is that data analysis, where I'm estimating the causal effect using data, using statistical methods for however I emulated the target trial. And an important thing to keep in mind is that those first 2 steps, specifying the target trial and designing the emulation of the target trial, often require a bit of iteration to ensure a balance between practical relevance. So I may be interested in answering a question about a very general population, and but then my observational data captures a very specific population, like a clinical population, for example. So I have to know that it's going to be only feasible for me to focus on that population. So I have to sort of tailor the target trial a bit to what is going to be feasible, but not too much that then what I'm answering is a question that is no longer relevant for practice. So there's a bit of a tension there between the two, and it requires sort of finding a balance to that. All right, so I said I was going to illustrate the framework with an example. So this example comes from our work here at MCRI. So the research question was looking at the impact in females of sustained frequent cannabis use for 2 years from ages around 15 to 16 versus using no cannabis on the risk of depression and anxiety in early adulthood. So as you can imagine, running a randomized trial for this question is, I mean, you may know more than me, but I imagine it's like either unethical or infeasible or very difficult, at least, to recruit people into it. So infeasible in that sense. And also it would require time, right? Like 6 years or something of follow-up. So what we can try to do is answer this question using observational data. And what we're going to use is, what we used in this study is data from the Victorian Adolescent Health Cohort Study, which is a population-based longitudinal cohort, sort of a research study that recruited 1,000 females around 1992 and 1993 using a two-stage cluster sampling approach where classes were sampled from schools from a stratified frame of schools across Victoria. And these participants, I believe now they're 45 or 50, but for this study, we're going to focus on the first 7 waves of data collection, which started in, we have adolescent surveys every 6 months when they were aged 15 to 18. And then there's a young adulthood survey that assessed mental health around when they were 20 to 21 years old in wave 7. So we're gonna now go through how we would use the target trial framework to design, sort of define our estimate and then design the emulation of that estimate, sort of design our analysis using the target trial framework. So the first step is to define the estimate, but in the target trial framework, that means to specify the protocol of the hypothetical ideal trial that would answer the question. And that's what is called the target trial. So the protocol consists of things that you would think about in an actual trial. So what is the eligibility criteria? What are the treatment strategies, the assignment procedures, the follow-up period, the outcome, and then the causal contrasts of interests. So we're going to go one by one in this example. But before that, I just want to stop and define what I mean by an ideal trial. So essentially, it's a trial that is infinite in sample size. We have a study sample that is representative of the target population. If there is no missing data, so our analytic sample coincides with the study sample. There's randomized assignment, although that is kind of irrelevant because once you have the target population and you have an infinite sample of it, it's the same to sort of assume that you're randomizing it, or just think about randomizing that study sample infinite into the 2 arms, or thinking about whether you're treating the whole target population under one or the other intervention. Anyway, sorry, that aside might have been a little bit confusing, so forget about it. That's a minor detail. Anyway, the next part of an ideal trial is that there is perfect adherence to the strategies, the treatment strategies that people are assigned to. And then finally, there is no measurement error. In particular, we're using sort of the gold standard outcome measure. So that's what I mean by an ideal trial. So in the VAX example, if we start to specify each of those target trial protocol components, we might start with, we start with the eligibility criteria. So that really is about what is our target population. And one important thing when we're doing this is to think about the fact that everyone in that target population needs to have a positive probability of receiving each of the treatment strategies that I am interested in. Of course, that's kind of obvious, but it's important to say that. So in this study, the VAX example, we would be interested in a representative infinite sample of female adolescents aged 15 to 16 years who are attending school in Victoria and who have not initiated frequent cannabis use, because obviously we would imagine that past cannabis use would be also a cause of later outcome. And then the analytic sample would include all the study sample participants, as there is no missing data. This is an ideal trial. In terms of the treatment strategies, what we really need to think about is what are the strategies that we wish to compare where they're perfect adherence. And this must correspond to relatively well-defined interventions, although there's some ways of sort of relaxing that. And maybe this is a point that you don't have to worry about too much now. But anyway, so in this setting, the treatment arms would be, for example, if we look back at our question, it would be sustained frequent cannabis use, which frequent is defined, we can define it as at least monthly, for example, which is something we collect in the data. So sustained frequent cannabis use for 2 years, that's one of the treatment strategies. And then the other treatment strategy is no cannabis use for 2 years. And just going back to this issue of multiple versions, as I mentioned, I noted that I haven't said how cannabis is going to be used, what the dosage is, and so on. And that might make these interventions that I'm talking about a bit ill-defined, but the assumption is going to be that there's no variation in outcomes by all these versions. And one might dispute that assumption. Then finally, not only do we need to define what our treatment strategies are, but how we would measure adherence. But because we're in an ideal trial, adherence is perfect, then we don't really need to worry about that. We assume it's all perfect adherence. The assignment procedures would be randomization and recruitment without blind assignment. Obviously, blind assignment would be impossible in this setting, which is why Miguel Hernal always says target trial emulation serves to emulate pragmatic randomized trials, not randomized trials where you would potentially be able to do some blinding. And then follow-up period is basically setting the time at which we start following participants and then when we end. So we started when they're aged 15 to 16 years and we end when we measure their outcome at 20 to 21 years. And then finally, the outcome measure is a clinical diagnosis of depression or anxiety disorders using the WHO Composite International Diagnostic Interview. That would be the gold standard measure in this setting. All right, so that is the specification of our target trial, which is an ideal trial with some really nice properties. Oh, and I was forgetting about the causal contrasts of interest. So there's always mention, I guess, of two common causal contrasts. One's the intention to treat effect, which is the effect of allocation, and then the other one is the per protocol effect, which is the effect on adherence to the assigned strategy. That's what Miguel and people who develop the framework mean by causal contrasts. If we specify the ideal trial based on the strategies that we're interested in under perfect adherence, then what we're interested in is the per protocol effect. But also because we're in an ideal trial and there's perfect adherence, both effects will be the same. So essentially, it's kind of redundant to say that we're interested in the per protocol effect, which is equal to the intention to treat effect, which contrasts outcome under perfect adherence to the two strategies that we specified. And then the causal effect measure is how we sort of operationalize that contrast. Do we want to look at the ratio of risks? Do we want to look at the difference in risks? In this case, maybe we want to look at the risk difference. There's different considerations as to what we choose there, but we're not going to go into those details. All right, so here is like a table that summarizes the target trial specification that I just mentioned. And just so that we keep it there all together. So then we go to the second part, right? That's going to be potentially the trickiest bit, is how we are going to emulate that ideal trial with the observational data from the VAX study. And importantly, as I had mentioned before, in going from the target trial to the emulation, we are going to need some assumptions, some causal identifiability assumptions that we cannot verify from the data in order to emulate that target trial. So we're going to talk about how we emulate each protocol component and the assumptions that are required in each case. So in terms of the eligibility criteria, we might define our study sample as all female adolescents participating in the VAX cohort at wave 2 of the cohort, which started at around 15.5 years, and who have never, and we will exclude those who have never used cannabis. We will exclude those who have used cannabis based on that wave 2 measure, which is a retrospective measure. At wave 2, they asked, have you used cannabis in the past 6 months? So we're going to exclude them, and that's how we're going to emulate this eligibility criterion of who have never used cannabis. And we are going to define the analytic sample as all these participants in the study sample, regardless of missing data, because we're going to deal with missing data using multiple imputation, as I'll talk about later. So we do have missing data, obviously, in the VAX study, and we're going to deal with it, and that's going to require some assumptions. So the first assumption when we look at that emulation strategy is that the VAX participants are representative of this target population. And it really depends on whether that two-stage sampling, cluster sampling procedure that I described achieved representatives. It was quite a well-designed study, and sort of descriptions of the cohort sort of seem to make it plausible that it's fairly representative of the target population. So that assumption may be plausible. What's more questionable is another assumption, and is that the self-reported cannabis use at wave 2, which we are using to emulate this eligibility criterion, is accurate, so that there's no misclassification. That's questionable because we know self-reported measures, in particular about substances like cannabis, may be inaccurate. And then finally, as I said, we're gonna use, if we're gonna use something like multiple imputation to handle the missing data, that relies, whatever we do with the missing data basically relies on assumptions about the missingness mechanism. And so it depends on what those assumptions are. We're not gonna go into the details of that. That's a whole sort of topic, but essentially whether we're gonna have plausible assumptions depends on whether we have auxiliary variables to make those assumptions as relaxed as possible. Not going to go into that. That's a whole other short course or talk. But that's one of the assumptions. Okay, so now we go into the emulation of the treatment strategies. So the treatment arms in the emulation are going to be the same ones, but how are we going to emulate them? Or emulate sort of adherence to those strategies. And to do that, where we're going to have to use, obviously, is the self-reported cannabis use over all the waves of data collection over adolescents, which are all 6 monthly self-reported cannabis use in the previous 6 months. So obviously that again relies on that measure, that self-reported measure over each of the waves being accurate, which again, as I mentioned, is questionable, but that's what we have. This is always like this in causal inference. You have all these assumptions that you have to make, and the whole game is to actually make them transparent and try to relax them as much as possible. All right, in assignment procedures, we obviously don't have randomization. We obviously don't have any blinding. So what we're going to do to classify individuals into treatment strategies in our data is to classify them into the treatment strategies that are consistent with what they have reported at wave 3 in terms of cannabis use in the past 6 months, which goes back to our time 0 of 15.5 years. And so at time 0, we classify people based on what they reported at wave 3, and then we're going to follow them up and then censor them if they deviate from their strategy. And then we're going to have to use some kind of inverse probability weighting or something like that to tackle that censoring that we're doing. And I'm going to talk slightly more about that later. But this approach is essentially a way to tackle with the time varying confounding that is leading people to change treatment strategies. And so the assumptions that we rely on there are that we don't have any residual confounding given all the measured baseline and time varying confounders that we're gonna use. And so I'm gonna show you a causal diagram here that shows sort of our assumptions in this study. So we have the exposure, frequent cannabis use over each wave of data collection. Remember, we start with what was reported at wave 3, and we have selected everyone who didn't use cannabis use before based on the wave 2 measure. So we have frequent cannabis use over waves 3 to 6. That's the adherence measures or the exposure measures that we're going to use to classify individuals and to decide whether we need to censor them. And then these variables here, C, Z, are all confounders that we have measured at baseline, parental education, and then over time, things like parental divorce or separation, antisocial behavior, depression and anxiety. It's a key one that is obviously going to be affected by cannabis use and is going to affect future cannabis use, alcohol use, and those are the ones that we have in the study. And so obviously you might question whether we're missing there some key confounders that might make this assumption of non-residual confounder plausible. I should have mentioned here we have the outcome, depression and anxiety at age around 21. Either way, the ages here are sort of median ages at those waves for the VAX cohort. All right, now we go to the follow-up period. So the key, it's not really a causal identifiability assumption, but it's a principle that we need to try to make hold when emulating a target trial, which is something that holds naturally in a randomized trial. So in a randomized trial, the timing at which you assess the eligibility of participants for the trial, and you start following them up, and you randomize them to treatment strategies, are all in alignment. Now we need to see whether that is going to hold in our emulation. So I stated that it does hold because time 0 is 15.5 years. That's how we have defined it. The time at which we are assessing eligibility is at wave 2, which has median age 15.5 years. And the time at which we're classifying individuals into their treatment strategies is based on the wave 3 measure of cannabis use in the past 6 months. So at wave 3, they're about 16 years of age. 6 months before is going to be when they're 15.5 years. So in this emulation, we have aligned time 0, timing at which eligibility is assessed, and the timing of treatment assignment. So that's good. And I'm going to talk later about issues that happen when that's not aligned. But this is, I guess, the key thing to think about in this protocol component. In terms of the outcome measure, what we have measured in the VAX study is the CISR score, which is an instrument used for population health screening of mental health disorders. And there's a cutoff of 12 that has been validated as an indicator of presence of depression or anxiety. So that's what we're going to use to emulate the gold standard CD measure. And so obviously it depends on the accuracy of that variable. And it's, as I said, it's plausible because we have that established reliability and validity, but obviously it's not perfect. All right, so here now we've talked about how we're going to emulate each protocol component. And I didn't mention the causal contrast because essentially the per protocol effect in the ideal trial is going to be what we're going to target, and it's going to be emulatable under all those assumptions that I mentioned before. All right, so that's the target trial specification, the emulation, step 1, step 2, and then step 3 is to now having designed the emulation, specify the data analysis plan for the emulation based on those identifiability assumptions. And this is where we go and actually analyze the data, and that often relies on parametric modeling assumptions that may be wrong, and that's sort of the assumptions that are embedded in tools like regression and so on. So here we need to think about what statistical methods we're going to use to adjust for confounding, to deal with selection bias, for example, due to missing data, and with measurement error. So there's a range of confounding adjustment methods that have been developed within the causal inference literature, like inverse probability of treatment weighting, G-computation. Outcome regression is also a confounding adjustment method, although it doesn't really work when we have time-varying treatments like here. We can think about methods to handle missing data, like multiple imputation, also inverse probability weighting, and so on. I'm not going to talk about all the, that's basically talking about a whole bunch of different areas of statistics, or of causal inference, like different methods to deal with each bias. But essentially in the data analysis plan, we decide what to do about each bias and how to combine everything. And then each of those methods, as I was saying, relies on its own modeling assumptions. So an example of what we would do in the VAX example is to use inverse probability weighting to adjust for baseline and post-baseline confounding. And because of its flexibility, we might use multiple imputation to handle all the multivariable missing data in the cohort study, including some auxiliary variables from the cohort study. And we might not attempt to correct for misclassification in the exposure. Measurement error methods are a bit tricky because they require external parameters about the sort of reliability of the measures. And those are really tricky to obtain. And I think that's why no one really tries to fix to adjust for measurement error. So, but that's sort of obviously a key potential source of bias that needs to be acknowledged as a limitation. And that's it. So that was the whole example of how we can sort of use the target trial framework within this example. And I just wanted to mention the target reporting guidelines that were developed sort of to show how you might go and report such a study. So before finishing, I'm just looking at the time. I don't want to take too much time. I'll just quickly touch on the advantages and limitations, challenges of the approach. So the advantages is really that it's a more accessible approach than sort of the mathematical theory of causal inference, but it's consistent with it in that it encourages the key distinction between the 3 steps that I touched upon. So the causal estimate, the identifiability, and the estimation. And it makes, in terms of the causal estimate, it facilitates a precise definition of the causal estimate, including details that are usually left quite vague by the mathematical approach, such as the target population. In terms of identifiability, the concept of the hypothetical trial really facilitates sort of assessing the assumptions and also systematic identification of potential biases. And quite importantly, it helps avoid what Miguel here now calls self-inflicted biases that I'm going to talk about in the next slide briefly. And within the framework, novel approaches to deal with those biases have been developed. And then finally, in terms of estimation, the framework can be used in conjunction very naturally with all the modern approaches for estimation of causal effects in the causal inference literature. So just talking a bit about these self-inflicted biases, one sort of to illustrate with the VAX example, if we didn't have the idea of this hypothetical trial in mind and thinking about eligibility into the study based on how we would do that in a trial, we might not think about having an exclusion criteria like excluding people who have initiated frequent cannabis use in the past. In a traditional observational study, we might sort of take the whole cohort and then start to look at the exposure of people at wave 2, have they used or not used cannabis, and similarly wave 3, and so on. And the issue with that is that we have a misalignment between time 0 the timing at which eligibility are assessed, which are both aligned similarly as before at time 15.5. But the time of treatment strategy initiation, it's not really assignment, initiation is misaligned because at time 0, we're going to have all these people who actually already started in the past, so are prevalent users of cannabis. So their timing of treatment strategy initiation is misaligned. And that can lead to exposure misclassification bias, because it's kind of unclear how do we now assign people to the different, classify people into different strategies. It can also lead to selection bias, and I'm obviously not going to go into all these details, but there's papers cited there that talk about that. Both these issues are what lead to so-called immortal time bias in studies, that's more in studies that are have people with mortality and so on, which is not so much the case, obviously, in the VAX example. And when you have these issues, then it trickles into other issues, like how do I adjust for confounding? Now, for example, the confounders at time 0, I might actually consider them, they're actually like mediators of past exposure and future. So I don't know what to adjust for and when to adjust for things. And it all becomes messy and biases start to creep into the study. So having the concept of the hypothetical trial, and in particular this idea of aligning timings, helps us avoid all these messy issues that are really self-inflicted and avoidable. And as I mentioned, these sort of creep up a lot when there are in two situations, when individuals may meet eligibility criteria at multiple times, which happens a lot in healthcare databases, EMR, and so on, or registries, and when treatment strategies remain indistinguishable for some time. So I'm just going to cite quickly this paper in the BMJ by also Miguel's group, Starting Right, which sort of illustrates really nicely these different approaches, the sequential trials approach and the clone sensor weight approach to deal with these issues. And then finally, the limitations and challenges. So in terms of the causal estimate, as I mentioned before, there's this inevitable tension between the practical relevance and the feasibility of estimation when you're specifying your estimate, whether you're using a target trial or framing or like a mathematical framing, for example. And there has been an increase of the use of what I call the aligned approach, where in the spectrum, in the alignment of with the observational data, people are trying to sort of specify the target trial in a way that's really aligned with the observational data, which is more feasible to estimate, but it really gets away from the ideal trial that answers the relevant question. So that there's a critique there in that paper, the trial paper that I've cited, where I talk about a lot of the things that I've talked about today. And then in terms of identifiability, so the other two steps, identifiability and estimation, it is important to note that the target trial framework cannot help you avoid other biases or non-self-inflicted biases that may threat observational studies if the causal identifiability assumptions or the parametric modeling assumptions are violated. So there may still be confounding bias, selection bias due to missing data because our assumptions don't hold, measurement bias, and misspecification bias. So we cannot, it's not going to solve these issues that are inevitable in observational studies or actual trials. So finishing with the actual trials. So I was saying that beyond intention to treat as an estimate, the analysis of RCTs amounts to causal inference with observational data. In the sense that then you have to deal with all these events like non-adherence and so on. And so in principle, you could use the target trial framework to analyze randomized controlled trials. And I thought I would just quickly mention the ICH estimate framework, which I know is more widely used, I guess, by this community, and is another framework to specify causal estimate. So it's another framework to do step 1, and just sort of reflect a bit on the pros and cons. So pros, from what I've heard from my colleagues at CIBU who work in trials, And it's clear it really allows the specification of really highly detailed estimates that consider the real complexities of trials. So in the face of when you have multiple intercurrent events, you can decide how you treat each of them, and that's fabulous. The cons, in a way, is that the link to the two next steps is a bit more tenuous, from my understanding, in the sense that you somehow cannot get around sort of thinking about the mathematical definition of these estimates and then thinking about the causal identifiability assumptions in order to produce appropriate estimation procedures. So I think there's potentially a little bit of work to do to sort of take this framework to the next level. And there's some papers out there that sort of are doing those connections. I don't want to say that there isn't a lot of work going on there, but just to sort of highlight and connect to the target trial framework. And that's it. Thank you for listening. I want to thank my team with whom we sort of talk about all of these things, develop courses. And we have a course on observational studies that really goes into the details of this. So there's a QR code there that people can look at. And that's it, Andrew.
So thanks very much, Margarita, for a wonderful presentation. We've got a couple of questions that have come in, but I'll start off from me, and I made some notes during it, and I was going to say, oh, there's such close alignment with the ICH STInG framework there. So your focus was on an ideal trial, which in the STInG framework we'd probably call that a hypothetical STInG, but your target trial.
I don't think that's it. The hypothetical estimate, I think you're talking about the hypothetical strategy to deal with specific intercurrent events.
No missing data, no dropout, no treatment discontinuation. There's a continuum of hypothetical strategies.
Yeah. Okay. Yeah. I guess in some way, yes, I assume so.
But in the target trial framework, you can also specify like an intention to treat, or called treatment policy target trial as well too. So people do conduct trials with the intention of looking what happens according to people, randomized or not. So it's not always about the ideal trial or perfect adherence, etc. Yeah.
So can I stop you there to clarify something? So you can specify all these things that you just said, like if you're interested in the effect of assignment, or if you want to treat one intercurrent event as hypothetical, but the other one as with another strategy, all of those things can be specified in the protocol components of the ideal trial. So that's why I do keep sort of disagreeing with you with that the ideal is the hypothetical estimate, because I don't think that's it. So for example, if you're interested in the effect of allocation, as I was saying, when you specify the treatment strategies, you would specify them as what you're interested in. So you would specify treatment strategy 1, allocation to blah, 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 treatment strategy 2, allocation to blah, blah, blah. So that's, and in that case, again, people by default adhere to it. It's a point strategy, basically. It's a point treatment, and intention to treat pre-protocol are equivalent. Similarly, if you had competing events and you don't want to, for example, competing event of death that you obviously don't want to treat through a hypothetical estimate, but you want to treat it in some other way, you would incorporate it in the protocol in the same way that it can be incorporated in the components of the estimate framework strategy. Right. So it doesn't, it's completely mutable, one approach to the other. I think.
Oh, I agree. No, that was what I was saying. I think there's really a one-to-one correspondence between the two, and it's not like in trials we're saying do this, and if we're emulating target trials we do something different. I think they're completely compatible. Let's go to one of the questions in the chat here.
Just to say, I have a forthcoming letter that makes that link a bit more, so I'll
okay, good.
circulate.
Great, yeah, thanks. I see how all this information is used to improve causal. I'm still a little unclear on specifics on how we'd actually use info to improve causal interpretation. Seems like there is an art to the reporting. Could Margarita talk a bit to this a bit? I don't know if you could see the text of the chat yourself there.
Oh,
Margarita.
sorry, no, I have. I
Yeah.
haven't.
I'm not exactly sure what the question is here. Still unclear on the specifics of how we'd actually use. Oh, Chris, if you happen to be there, could you just yell out with sort of a little elaboration on your question? I think it's been voted up twice, so it's a good question, but I'm not quite grasping it. I'm not sure. Can you read that? Can you?
I'm reading the question, yeah, but I'm still a
Yeah.
little clear on the specifics of how we actually use this info to there is an R2 reporting. Yeah, the question is a little unclear, but I guess just what the developments in causal inference have done, and that I think the target trial framework helps to do. Oh, Chris, are you going to talk?
I undid my mic, so thank you for that. Yeah, it was a really cool presentation. Thanks. I'm just getting my head around all this target trial stuff, and causal improving causal inference is a huge thing for us at the moment, so it's great. I guess my question is, I kind of get like the table at the end. You've got you've got your perfect target trial, and then you're talking about how the thing you actually did matches to that. Very useful information. It's like DAGs, very useful information. But actually using that to improve causal interpretation and inference is another step. And it seems like that other step is how you report it, how you talk about what you did. So, does that make sense?
Yeah, a little bit. Like, I guess by improving causal inference, I guess, what is improving causal inference? It would be to rely on the most relaxed assumptions possible, right? So I talked about how going from this column to this column, we're always needing some causal identifiability assumption. And indeed, by having these two things side by side, firstly shows that they're different, and then there's more rows here that I wasn't able to put in here, like where you could put the identifiability assumptions to make them really transparent. What are the assumptions that are linking this to this? And knowing that helps to know what your conclusions rely on, and therefore the interpretation in terms of knowing what the limitations are or how strong the results, how strong the study is. So it's in that way, I think, that it helps strengthen causal inference or strengthen appropriate causal interpretation, I guess, is more what I think is the aim here. If that
so
makes
it's kind of like a DAG in that it helps you identify any potential problems, as well as showing you the strength of what you've done. So when you write up, you can talk to those things and you can explain to people why you think there's strong causal inference versus not so strong, for instance.
Well, you have to think about all the assumptions, and that, as I showed, is part of it. It's all part. I think the main point is to make all the identifiability assumptions really transparent. And therefore, in doing so, you yourself designing the study might find ways to relax them. So as you said, maybe work out, oh, maybe this is a confounder that I need to adjust for as well, or maybe this is not the best way to deal with missing data, whatever. So it helps you design the best study possible, and then also make clear what assumptions that relies on. And in that way, it strengthens the appropriate interpretation.
Okay, thank you. Thanks.
I hope that makes sense.
Yeah.
Thanks, Marita. I hope you can stay on just 2 more minutes.
Yeah.
We've just got a couple of questions that I'll sort of summarize quickly. They're both about confounding in different ways. The first question is about measures to assess sensitivity to unmeasured confounding.
Mm-hmm.
Yeah. Are there measures to?
Oh, are there?
Yeah. Yes.
There.
Oh no. Are there any methods to assess unmeasured confounding? So yes, there are.
There
but
is.
You can address that. Yeah.
Yeah, there's a bunch of methods within causal inference literature to do that, and they should be used here in the same way as other methods for estimation of causal effects.
Yep. Okay, and the second one is about with time varying confounding being an issue, that we need frequent waves of data collection. But in reality, a lot of cohort studies don't have frequent ways of data collection. So how much of this is a problem?
It's a huge problem, I think, if you're interested in longitudinal treatment strategies, and you don't have the time varying confounders. If you measure how the treatment varies over time, but you haven't measured anything else to see what's affecting that, that's a huge source of time varying confounding. And that's why I think, well, in trials, if you're interested in protocol effects or like dealing with intercurrent events in ways that are not just treatment policy or whatever, you also should be thinking about measuring all these longitudinal things that are going to be impacting the assumptions, that are going to relax the assumptions that you need to deal with the intercurrent events. So that's a big problem. Yeah,
so I guess the moral stories when setting up cohort studies, have the target trial in your head already at the design stage.
Yeah.
Yep. Okay, I think we need to wrap up now. So let's thank Margarita once again. And we had a record number. I think we had 68 attendees here, Margarita, which is wonderful. Our next webinar is on the 5th of May, and it's going to be about benchmarking outliers for clinical quality registries. So today's talk had a lot of application to registries and the sorts of questions, the sort of the what if causal questions that could actually be addressed in registries that are probably not being capitalized on so far. And then next time we'll hear some more about registries and about outlier detection. So thank you very much, everyone, for joining, and let's thank Margarita once again, and we'll see you again next time. And please complete the survey too.
Thanks, Andrew. Thanks, Sol.
Okay, bye.